You're listening to the Hoofcare Companion, the podcast dedicated to the science, art and practicalities of keeping horses sound from the ground up. I'm your host, Marc Jerram, and each episode will take a deep dive into the world of hoof anatomy, pathology, care and rehabilitation. Whether you're a farrier, veterinarian, therapist or simply passionate about horse health, this is your space to learn, question and grow. We'll explore the latest research, time-tested methods and real-world case studies to help you better understand the structures beneath the hoof capsule and how to support them when things go wrong. Because good hoof care isn't just about trimming and shoeing, it's about understanding the whole horse. So let's get stuck into today's topic. Episode 5, Pedal Bone Fractures.
Introduction.
Pedal bone fractures, also known as fractures of the distal phalanx or P3, represent a significant but often manageable orthopaedic injury in equine practice. The pedal bone is located within the hoof capsule and plays a vital role in weight bearing, force transmission and hoof capsule architecture. Although protected by the surrounding structures of the hoof, it is not immune to trauma or pathological stress that can result in fractures. These injuries can occur acutely, often due to a traumatic incident such as a kick or stepping on a hard object, or insidiously as a result of repetitive concussive forces that exceed the bone's structural capacity, particularly in performance horses. Recognition of pedal bone fractures and their prompt diagnosis is critical for successful treatment outcomes. Modern diagnostic modalities including radiography, computed tomography, CT and magnetic resonance imaging, MRI, have greatly enhanced the clinician's ability to accurately classify and localise pedal bone fractures. Treatment protocols are then tailored to the type of fracture and the horse's athletic function and the owner's expectations, with both veterinary and farriery strategies playing essential roles in recovery.
Classification.
Pedal bone fractures are typically classified according to the type and location of the fracture. The most commonly referenced system was developed by Trotter and Associates, which describes 7 types of fractures based on their configuration and anatomical involvement. Trotter et al., 1985. Type 1 fractures are non-articular wing fractures, typically lateral or medial, and do not involve the distal interphalangeal joint, DIPJ. Type 2 fractures extend from the articular surface of the DIPJ to the wing of P3 and are considered articular fractures. Type 3 fractures are mid-sagittal splits that also involve the DIPJ, whereas Type 4 fractures are extensor process fractures. Type 5 are comminuted fractures and are more complex, often involving multiple planes and pieces. Type 6 are solar margin fractures that often develop secondary to chronic laminitis or repetitive concussion, and Type 7 are found in foals and involve the palmar or plantar processes. Accurate identification of the fracture type is essential to determine prognosis and appropriate treatment protocols. Nixon, 1996.
Clinical signs.
The clinical presentation of pedal bone fractures can vary considerably depending on the type and severity of the fracture. Horses with acute pedal bone fractures often present with sudden onset, severe lameness, which may mimic solar abscesses or laminitis in early stages. There may be increased digital pulse, heat in the hoof, and a positive response to hoof testers applied over the affected area. In some cases, particularly with type 1 fractures, the lameness may resolve rapidly with rest, leading to delayed diagnosis. Conversely, type 3 and 5 fractures are typically associated with more profound lameness and prolonged discomfort. Accurate and timely diagnosis relies heavily on imaging, beginning with standard radiography. Radiographs taken at multiple angles, including dorsopalmar, lateromedial, and oblique views, are necessary to identify fracture lines. However, in the early stages post-injury, fractures may not be readily visible due to overlapping structures or minimal displacement. In such cases, repeat radiographs after 7 to 10 days may be necessary as bone resorption highlights the fracture margins. Advanced imaging such as CT and MRI offer superior visualization, especially for complex or occult fractures. Barber et al., 2006.
Treatment.
Once the fracture has been classified, treatment options can be considered. Non-displaced fractures, particularly type 1 and some type 2 injuries, can often be managed conservatively with stall rest and therapeutic shoeing. Horses are typically confined to box rest for a minimum of 8 to 12 weeks, with gradual return to exercise based on clinical signs and radiographic healing. Analgesics such as phenylbutazone are used during the initial period to control pain and inflammation. In cases where fractures are significantly displaced, involve the joint surface, or fail to heal with conservative management, surgical intervention may be necessary. Internal fixation is rarely performed for P3 fractures due to the difficulty in achieving surgical access and the high risk of contamination in the hoof environment. However, lag screw fixation of sagittal fractures has been described and can be performed in specialised settings using advanced imaging guidance. Richardson et al. 2003. Another surgical approach involves the use of palmar digital neurectomy in cases of chronic, unresolving pain, particularly for solar margin fractures. However, this is considered a salvage procedure and carries ethical and welfare considerations. In some instances, therapeutic shoeing alone may not suffice, and techniques such as hoof cast application or transfixation. Pin casts are used to achieve greater immobilization of the digit, Hunt 1993. Additionally, adjunctive therapies including extracorporeal shockwave therapy and regenerative medicine, approaches such as platelet-rich plasma, PRP, and stem cell therapy have been investigated for their potential to accelerate healing, though their efficacy in pedal bone fractures remains under continued study. Fortier and Smith, 2008.
Management plan.
Owner management during the rehabilitation period is a critical component of successful recovery. Horses undergoing treatment for pedal bone fractures must be confined to strict stall rest, often with deeply bedded environments to reduce concussion. Hand walking and controlled turnout are introduced only under veterinary guidance. Rechecking diagnostic imaging is essential to monitor healing progression. This is typically every 4 to 6 weeks during the rehabilitation phase. Diet should be carefully managed to avoid excessive weight gain during the period of inactivity, while ensuring adequate levels of calcium, phosphorus, and vitamin D to support bone repair. Gior and Harris, 2013. The mental well-being of the horse during extended rest should also be considered, and enrichment strategies such as mirrors, slow feeders, and consistent routines may help reduce stress and anxiety.
Farriery treatment.
Farriers play an indispensable role in the rehabilitation and long-term management of horses recovering from P3 bone fractures. Once healing has progressed sufficiently to allow for controlled exercise, the trimming strategy should aim to maintain a balanced foot with a strong hoof wall and healthy solar structures. The importance of mediolateral and dorso-palmar balance cannot be overstated, particularly in preventing abnormal strain on the healing or previously injured pedal bone. Radiographic guidance is often employed to monitor hoof balance and the alignment of the distal phalanx within the hoof capsule. Molerman et al. 2006. One of the most commonly used approaches is the application of bar shoes, such as heart bars or straight bars, which provide increased stability and limit hoof expansion during weight bearing. These shoes help offload the affected portion of the pedal bone and reduce strain on the fracture line. In cases where additional immobilization is required, such as with more severe or articular fractures, a hoof cast may be applied over the entire hoof and shoe, acting like a plaster cast for the foot to dramatically limit movement and absorb concussion. Another advanced option includes glue-on shoes, which are particularly useful when nailing is contraindicated due to pain, hoof wall damage, or poor horn quality. These shoes can be made from composite materials and bonded directly to the hoof using acrylic or urethane adhesives, reducing vibration and shock without the need for nails that could cause further trauma. Additionally, shoes with multiple clips can be used to anchor the shoe more securely and limit hoof capsule distortion during movement. When carefully applied, these modifications not only improve mechanical support but also help reduce discomfort, preserve hoof integrity during the rest period, and support the horse during the gradual return to work. Each farrier plan must be tailored to the type of fracture, the location within the pedal bone and the horse's conformation and workload, ideally guided by radiographic assessment and in collaboration with the attending veterinarian. Preventative strategies are also important in managing horses at risk of pedal bone fractures. These include ensuring appropriate footing in arenas and turnout areas, maintaining regular farriery appointments to optimise hoof balance, and tailoring training regimens to avoid excessive repetitive strain. Performance horses in disciplines such as eventing, racing and show jumping are particularly susceptible to concussive forces on the distal limb and should be monitored closely for subtle signs of discomfort. Additionally, dietary management to support bone density, particularly in growing horses and those in high intensity work, can contribute to long-term skeletal health. Genetic factors such as conformation and hoof capsule integrity also influence fracture risk and should be considered in breeding and training programs.
Prognosis.
The long-term prognosis for pedal bone fractures varies according to type, severity, treatment modality and the horse's intended use. Type 1 fractures often carry an excellent prognosis for return to full function, including athletic performance, especially when promptly diagnosed and appropriately managed. Type 2 and 3 fractures may result in residual joint changes, particularly osteoarthritis of the DIPJ, which can limit high performance activities but may still allow for lower level use. Type 5 fractures are often career-ending due to the complex nature of the fracture and the likelihood of chronic pain or instability. Similarly, solar margin fractures in laminitic horses typically reflect underlying structural compromise and often correlate with a poorer prognosis due to the systemic disease process and poor hoof quality. Extensor process fractures, type 4, may not cause significant lameness unless large or associated with DIPJ involvement. Surgical removal of detached fragments is sometimes performed arthroscopically or through a dorsal hoof wall window if conservative management fails. Wagner and Baxter, 2011.
Conclusion.
Pedal bone fractures in horses are a complex but manageable condition that requires a multifaceted approach involving accurate diagnosis, veterinary treatment, farriery intervention and meticulous rehabilitation. The prognosis varies widely depending on fracture type and management strategies, but with timely and appropriate care, many horses can return to previous levels of function. The integration of imaging, surgical options, therapeutic shoeing, and owner compliance all contribute to successful outcomes. Continued research into regenerative therapies, advanced imaging and improved shoeing materials offers promise for enhancing recovery and long-term soundness in affected horses. Thank you for listening to the Hoofcare Companion. Please follow, rate and share this podcast on your social media to help the Hoofcare Companion grow and reach all of those who care for our equine friends all around the world. Visit the links in the show notes to obtain your copy of my books or to interact on my social media channels. Until next time, thank you for listening, because a healthy hoof is a happy horse.